I'd like to thank the organising committee for inviting me to present the results of the ARISE trial. As John said, they were presented at the ESICM in Barcelona last week, but this is the first opportunity to present it to ANZICS, and I'm very proud to do that. As John said, it was published in the New England Journal of Medicine last week, so if you haven't yet had a chance to go online, I would implore that you all do have a look. So, as most of you will be aware, the issue of early goal-directed therapy first arose following a proof of concept study which was published in the New England Journal of Medicine in 2001. And that trial demonstrated an impressive 16% absolute risk reduction in in-hospital mortality for patients presenting to the emergency department with severe sepsis and septic shock. Subsequent to this trial, there have been 3 iterations of the Surviving Sepsis Campaign guidelines, all of which have recommended that early goal-directed therapy be instituted not only for patients presenting to the emergency department with sepsis, the original cohort from the RIVER study, but in fact for all patients with severe sepsis and septic shock. However, this evidence has been graded of a low quality. Subsequent to the initial randomised controlled trial, there have also been over 20 non-randomised studies of bundled care which have suggested a survival benefit. More recently, in May of this year, the PROCESS multi-centre randomised controlled trial was published in the New England Journal of Medicine. This trial was a US-based study conducted in 31 tertiary care centres, and in the trial they enrolled just over 1,300 patients presenting to the ED within 12 hours with severe sepsis. There were 3 groups in this trial. There was those patients randomised to early goal-directed therapy, another group randomised to protocolised standard care, and then the third group which were randomised to usual care. And the primary outcome, which is early goal-directed therapy and protocolised standard care combined, was not found to be different to usual care with respect to in-hospital mortality, 19.5% versus 18.9%. Despite the results of the PROCESS trial, however, the questions regarding the generalisability of early goal-directed therapy remain unanswered. Early goal-directed therapy is a process of care intervention, and as such, its evaluation and widespread delivery are entirely context dependent. So the question is, can the results obtained in one region or organisational structure, such as the United States, be applicable across all other healthcare systems? Moreover, can the same intervention be faithfully delivered in a variety of hospital settings, tertiary such as that in the PROCESS study versus non-tertiary, and metropolitan versus rural centres? So the aim of the ARISE study was to test the hypothesis that, compared to usual care, EGDT would decrease 90-day all-cause mortality in patients presenting to the emergency department with early septic shock. The ARISE study was a prospective, unblinded, randomised, parallel group, multi-centre trial, and the study methods have been previously published in intensive care medicine. The trial was funded by the NHMRC and endorsed by the ANZICS CTG group, the Australasian College for Emergency Medicine, the College of Intensive Care Medicine, and the Irish Critical Care Trials group. And the study was run through the ANZIC RC here in Melbourne. There were 51 centres involved in the trial, predominantly in Australia, 41, but also in Finland, Hong Kong, New Zealand and the Republic of Ireland. The sites involved were a diversity of healthcare settings, including tertiary metropolitan, non-tertiary metropolitan and non-tertiary rural. And the range of ED presentations in the participating sites was between 15,000 and 200,000. Prior to commencing the trial, we undertook an observational study in order to understand what usual practice usual practice was in Australia and New Zealand. So this study involved 32 hospitals and 320 odd patients presenting to the ED. And we concluded from this observational study that usual care in our two countries did not include intermittent or continuous SCVO2 guided resuscitation. Also, prior to site selection, participating sites did not have a sepsis resuscitation protocols as part of their usual care. So the inclusion criteria were adult patients 18 years or over with suspected or confirmed infection and 2 or more SIRS criteria. Patients, in addition, had to either have refractory hypotension, defined as a systolic blood pressure less than 90 or a MAP less than 65 after a litre or more of intravenous fluid within 60 minutes, or hypoperfusion with a lactate of 4 or greater. And all of the inclusion criteria had to be met within 6 hours of ED presentation whilst the patient was still in the emergency department. And following meeting the inclusion criteria, randomisation had to occur within 2 hours. We also stipulated that prior to randomisation, commencement of the first dose of intravenous antimicrobial agents needed to occur. The exclusion criteria essentially related to primarily an inability to deliver any or all of the elements of the early goal-directed algorithm within the 6-hour intervention period. So, for example, a contraindication to a CVC insertion in the SVC, or a limitation of therapy order which would restrict implementation of the study protocol. We also excluded patients who weren't expected to survive 90 days. Following prior informed or delayed consent from the patient or their legal surrogate, patients were randomised 1-to-1 and stratified by site to receive either usual care or early goal-directed therapy for 6 hours. For patients randomised to the usual care group, all investigations, monitoring and treatments were determined by the treating clinicians. The only stipulation to care in the usual care group was that the SCVO2 measurement could not be undertaken during that 6-hour intervention period. For patients randomised to early goal-directed therapy, the algorithm was delivered by a dedicated study team consisting of at least one doctor and nurse and overseen by a study coordinator who had been trained in the delivery of early goal-directed therapy. However, the individual care providers and the location of care delivery was entirely dependent on local resources. So therefore, in some hospitals, this was entirely ED-based, in others ICU-based, and in others a mixture of ED and ICU, beginning in the ED and then transitioning through to ICU as necessary. In terms of the early goal-directed therapy resuscitation algorithm, the algorithm was essentially that as described by Rivers in the initial publication in 2001 and also as used by the process group. So an arterial catheter and an SCVO2 CVC were required to be inserted within 1 hour of randomisation. The resuscitation goals were an SpO2 of greater than 93%, a CVP of 8 or 12, depending on whether the patient was ventilated or not, a MAP of 65 to 90, and an ScVO2 above 70. And if any of these goals were not met in a sequential fashion, then patients received increasing respiratory support, fluid boluses, vasoactive agents, and red cell transfusions or dobutamine, depending on the hematocrit. Our primary outcome was all-cause mortality and 90 days post-randomisation. We also had a number of secondary and tertiary outcomes, including survival time from randomisation to day 90, ED, ICU and hospital length of stay, and the receipt and duration of invasive mechanical ventilation, vasopressor support and renal replacement therapy. We also looked at 28-day ICU and in-hospital mortality, where patients were discharged to for hospital survivors, and whether or not there was a limitation of therapy order in place at the time of death for patients who did not survive. In terms of our sample size, we assumed the baseline in-hospital mortality in the usual care group to be 28%. And this was based on two pieces of data. One was the ARISE Observational Study, which I alluded to previously, but also data from the ANZICS Adult Patient Database involving nearly 8,000 patients admitted to ICU from the emergency department with sepsis and septic shock. We then assumed a 10% increment in mortality to day 90, and with 1,600 patients, we had 85 to 90% power to exclude a 7.6% absolute risk reduction in 90-day mortality, which is about half that was observed by the original RIVER study, and this equated to a 20% relative risk reduction in mortality. We pre-published our statistical analysis plan not only prior to completion of recruitment of the ARISE trial, but also prior to completion of either the PROCESS or the PROMISE trial. Our 90-day mortality group differences were analysed using a Fisher's exact test, and we adjusted all of our analyses for 5 predefined baseline variables, that being country, age, Apache 2 score, a systolic blood pressure less than 90, and the presence of invasive ventilation prior to randomisation. We also conducted a number of subgroup analyses. Again, these were based on predefined baseline variables: country, age dichotomised at 65 years, Apache 2 score dichotomised at 25, invasive ventilation pre-randomisation, refractory hypotension, a lactate of 4 or greater, and the administration of 20 mils per kilo or less of intravenous fluids prior to meeting the inclusion criteria. So, coming to the results. Between 5 October 2008 and 23 April 2014, we screened 3,559 patients who met all of the study inclusion criteria. Of those patients, 1,600 were randomised, 796 to receive early goal-directed therapy and 804 to receive usual care. There were 9 patients who refused delayed consent. There was 1 patient who subsequently withdrew prior consent, and there was 1 patient in each group who was lost to follow-up. This left us with 792 patients in the early goal-directed therapy group and 796 in the usual care group for whom the primary outcome was available. This table here shows the patients who met the inclusion criteria and the volume of fluid they received prior to meeting the inclusion criteria. So we can see that patients in the early goal-directed therapy group received around 2.5 litres of fluid in order to meet the refractory hypotension criteria, and this was the same amount that the usual care group received. And this was around 35 mils per kilo. 70% of patients in both groups met the refractory hypotension criteria, and 46% in both treatment groups met the elevated lactate criteria, with the lactate at the time of meeting the inclusion criteria of just under 7. The time from presenting to the emergency department to meeting the final inclusion criterion was just over 1 hour, and the time to randomisation was just under 3 hours. There was no difference between the 2 treatment groups with respect to their pre-randomisation or baseline characteristics. The mean age was around 63 years, with around 60% of men. The Apache 2 score was 15.4 and 15.8. The vast majority of patients were admitted from home as their usual residence, and around 15 to 16% of patients in both treatment groups were receiving some form of mechanical ventilation prior to enrolment, and just over 20% of patients in both treatment groups were receiving a vasopressor infusion prior to randomisation. Microbiology was also not different between the two treatment groups, with around 36% in the early goal-directed therapy group and 33% in the usual care group having the lungs as the primary source of infection. And blood cultures were positive in 38% of patients in both treatment groups. The time from presenting to the emergency department to receiving the first intravenous antimicrobial dose was just over 1 hour in both treatment groups. In terms of the hemodynamic monitoring that was undertaken between the 0 and 6 hour study period, an SCVO2 catheter was inserted in 90% of the patients randomised to early goal-directed therapy, and the time to insertion was 1.1 hours, with the SCVO2 72.7. There were no patients in the usual care arm who received SCVO2 monitoring. For patients randomised to usual care, CVC was inserted in 61.9%, and the time to insertion, 1.2 hours, was similar to the time to insertion of the SCVO2 catheter. And arterial catheters were inserted in just over 90% of the EGDT patients and 76% of the usual care patients. Here we see the therapies that were delivered between 0 and 6 hours, and we can see that patients in the early goal-directed therapy arm received significantly more fluid in the first 6 hours, just under 2 litres versus 1,700 mils. There was also a significant increase in the number of patients who received vasopressors in the first 6 hours, red blood cell administration, and also dobutamine infusion. And these were all statistically significant. Interestingly, the increase in patients who received a vasopressor infusion and also who received a dobutamine infusion persisted between 6 hours and 72 hours, or there was no difference between the two groups with respect to the volume of fluid that was administered, nor in the number of patients who received a transfusion. This slide here represents the compliance with the early goal-directed therapy algorithm for patients randomised to early goal-directed therapy for the first 6 hours. The vertical bars represent the number of patients who either achieved the resuscitation endpoint, or if they didn't receive the resuscitation endpoint, actually received the appropriate goal-directed therapy. And we can see across the whole 6 hours for the 4 resuscitation endpoints that there was a high degree of compliance. And by the T5 to 6 hour period, the number of patients who either had met a particular resuscitation endpoint or had received the appropriate therapy was around 90% or greater for all resuscitation endpoints. Despite the high level of compliance with the algorithm, however, there was no difference between the early goal-directed therapy group and the usual care group with respect to attainment of the various physiological goals. So the darker bars, they look black here, but I think they might be blue. The dark bars represent the early goal-directed therapy group, and the orange circles represent the usual care group. And we can see that for SPO2, CVP, and also for MAP, that the 3 curves essentially overlap. There was no difference between the two treatment groups with respect to either these physiological variables or any other physiological or laboratory variables over the 6 hour period, except for a statistically significant 1 millimetre difference of mean arterial pressure, clearly not clinically significant, at the end of the 6 hours for patients randomised to the early goal-directed therapy, 76 versus 75. The primary outcome, not surprisingly, given the lack of difference in physiological variables, was not different between the early goal-directed therapy and usual care group. 90-day mortality for the EGDT arm was 18.6% versus 18.8% in the usual care arm. This gives an absolute risk difference of minus 0.3% with confidence intervals of minus 4.1 to 3.6. And we can see in the lower half of this slide that the two survival curves for the treatment groups also overlap. EGDT patients actually stayed for a shorter length of time in the emergency department post-randomisation, 1.4 hours versus usual care 2 hours. The number of patients who were also admitted direct from the emergency department to the ICU was also greater for patients randomised to early goal-directed therapy, 87% versus 76.9% for the usual care arm. However, this result needs to be interpreted in light of the fact that in some institutions, patients were required to be admitted to ICU in order to deliver the early goal-directed therapy algorithm. And in fact, of those patients randomised to early goal-directed therapy, 14% were only admitted to ICU in order to enable the study intervention. There were more patients in the early goal-directed therapy arm overall who also received a vasopressor infusion, 76% versus 65.8% in the usual care arm. However, for those patients who did receive a vasopressor infusion, there was no difference in the duration of administration. There was no difference between the two treatment arms in any other secondary or tertiary outcomes. In particular, we can see that there was no difference in ICU mortality or hospital mortality, which is around 15% in both treatment groups. There was also no difference in the number of patients who received invasive mechanical ventilation or renal replacement therapy, nor was there any difference in the duration of support. There was also no difference in the duration of stay in either ICU or in the hospital. As I said earlier, we did perform an adjusted analysis as well, and there was no difference in any of our unadjusted findings when we adjusted for our pre-specified baseline covariates of country, age, Apache 2 score, blood pressure less than 90, or invasive ventilation. And I've just highlighted here the primary outcome, the odds ratio unadjusted of 0.98 and 1.03 after adjustment. There was also no difference between the two treatment groups with regard to our predefined pre-randomisation subgroups, these being country, age, Apache 2 score, invasive mechanical ventilation, refractory hypotension, hypoperfusion, and the volume of fluid administered. So in conclusion, ARISE is the largest randomised trial of early goal-directed therapy for patients with early shock presenting to the emergency department. It's the only trial to be conducted in multiple countries and across a variety of healthcare settings. Delivery of the resuscitation algorithm was associated with a high degree of compliance. However, this compliance did not lead to an improvement in mortality, time spent in ICU or hospital, or duration of organ support, despite an increased use of intravenous fluids, vasopressors, red cell transfusions, and dobutamine in the 6-hour intervention period. Early goal-directed therapy has been incorporated into the Surviving Sepsis Campaign international guidelines as a standard of care. Our findings, in combination with those of PROMISE, would suggest that implementation of goal-directed resuscitation for all patients with severe sepsis and septic shock is not justified at the present time. Now, subsequent to this presentation last Wednesday in Barcelona, the Surviving Sepsis Campaign have actually issued a statement, just as they did after the process statement. And their response was that the evidence of the two trials is that CVP monitoring and SCVO2 monitoring are not associated with a survival benefit. However, they're also not associated with harm, and we should continue doing what they say, and in the meantime they will put together a committee to look at the evidence, and we all know what committees mean. Thank you. Oh, sorry, just one more thing. I wanted to acknowledge all of the members of the Working Committee, the Management Committee, the Coordinating Centre, the DSMB, and also to acknowledge Edwards and Roche, who very kindly loaned study equipment to the participating sites. And an especially big thank you to all of the participating sites who worked incredibly hard on what I think was an extremely difficult study to actually do. So thank you to everyone.